title was too long. I forget about that. Okay, it's almost there, and then I will go drop this link on Facebook. There we go.
So now, Amanda? Hello, everyone. We are so happy that you all have joined us. We want to thank you for tuning in, and we want to thank the Marinus team for allowing us this opportunity to hear about ganaxolone and opportunities regarding the expanded access program. I'm going to turn this over to Romy Nocera so she can get us started.
Hi, thank you, everybody. It's a couple minutes before actual noon Eastern time, so we're just going to wait a couple more minutes, and then there's some introductions and some housekeeping information that I would like to pass along to everybody before the actual presentation starts. So why don't we give it a couple more minutes, and then we will officially get started, if that's okay. Okay, we're just about there. So thank you so much to IFCR for that introduction, and thank all of you for joining us on this town hall today. We're very excited to be here, and special thanks to the IFCR for giving us the opportunity to do this. We will be presenting information about an investigational treatment for CDKL5 Deficiency Disorder. Prior to the presentation, we do have a few housekeeping items. Please do mute your microphone during the presentation, but please enter any questions you have into the chat. And after the actual presentation, there will be an ample opportunity for more Q&A. This call is being recorded, and the recording will be available at a later date. And at that time, if you watch it again, you'll have the opportunity to ask more questions that we will follow up on, or people watching for the first time will have opportunity to enter some questions, and we will be able to respond to those in time. You are welcome to keep your camera on. If you do so, please understand that this is being recorded and you're consenting to being recorded along with your image. So it's entirely up to you. Are there any questions at this time? If so, put them in the chat and we will address them as we go on. And I would like to introduce our speaker today. We have Dr. Ian Miller. Dr. Miller is a pediatric epileptologist who comes to us with a great deal of experience and expertise. He practiced in Miami for 14 years prior to coming to join us at Marinus just this past March. He has a long-standing clinical and research interest in genetic epilepsy, and we are thrilled to have him with us at Marinus, and we're so glad he was available to do this with us today. So without any further ado, I'm going to turn this over to Dr. Miller. Thank you, everybody.
Thanks, Romy, for that kind introduction. I'm going to start sharing my slides here, so I hope that shows up for everybody. Please put it in the chat if there's any technical problems. But it's really my pleasure to be able to speak with you this morning about ganaxolone, which is an investigational drug for CDKL5 deficiency disorder. And I want to echo Romy's gratitude towards the IFCR for inviting us to share this information and this news with you. This is a brief overview of what we're going to cover. Really, there's three main parts. The first is an overview of ganaxolone. The second is a review of the data regarding the use of ganaxolone to treat CDKL5 deficiency, which is the Marigold study. And then we'll look at ganaxolone compassionate use in CDD, which is an expanded access program that we're excited to be able to share with folks. We'll summarize, obviously, and then have some time for questions and answers afterwards if anybody has any. So in terms of understanding ganaxolone, I'm going to cover this at a relatively high level and do my best not to read the bullet points to you because there's a lot of detail in them. But it's a neuroactive steroid that is in clinical development for both acute and chronic seizure disorders. The thing that unites epilepsy into a single disease state is that it's basically an imbalance between excitation and inhibition within the brain. And things that cause epilepsy cause too much excitation, either because the excitation system is overactive or because the inhibition system is underactive. And ganaxolone is something that there was a reason to help with epilepsy because it activates the inhibitory system in the brain. And in the bullet list, you see there, that system is called GABA, G-A-B-A. So ganaxolone increases inhibition in the brain by binding to GABA receptors and increasing the GABA function, which decreases seizure activity. And you are welcome to take a screenshot of that link or write that link down if you want to visit the Marinus website, which has a little bit more information in terms of the mechanism of action of ganaxolone and a little bit more detail about how it works. The important thing for clinicians especially is to understand that ganaxolone works in a completely novel way relative to other seizure medications. Many seizure medications influence GABA, but there is no existing seizure medication or no approved seizure medication which activates GABA in the extrasynaptic receptors. And so that's what is exciting to us about ganaxolone as a treatment option because it allows us to increase the inhibitory activity of the brain in a way that we haven't been able to previously, which is obviously a step forward. So now let's shift gears and talk about what matters even more. You know, it's one thing to have an idea about why ganaxolone might be effective for a specific form of epilepsy, but it's even more exciting to take a group of individuals that have that form of epilepsy and actually measure its effectiveness in that group. And that's what the Marigold study was. The way that we measure effectiveness is by doing a double-blind, placebo-controlled clinical trial that evaluates the use, in this case of oral ganaxolone, in children and young adults with CDKL5 Deficiency Disorder. There were a total of 101 patients enrolled, which is an accomplishment for which we all feel pride because that's a lot of patients to identify and have participate in the study. Their ages ranged between 2 and 19 years of age. They had confirmed disease-related CDKL5 mutations present on their DNA testing. And each individual who participated had to have a minimum number of seizures of 16 major motor seizures per month. And they had to be taking up to 4 concomitant anti-seizure medications. And if you're doing a randomized clinical trial to measure the effectiveness of something, you want to kind of pre-specify what you're intending to measure and what matters and what that treatment is going to affect. And therefore, we chose the percent change in 28-day major motor seizure frequency as the endpoint. We felt that if we could show that ganaxolone as a treatment lowered the seizure frequency over 28 days in children with CDKL5 deficiency, that would be a meaningful, directly important result to have in hand. So how did we do that? This shows the schematic for the Marigold study and kind of the timing of how it worked. As we said, individuals who participated had to have 16 seizures per month for 2 months prior to the beginning of the study. They had a baseline counting period of 6 weeks during which they recorded when and what seizures occurred. They then had a 4-week titration period, which means increasing the dose of the medication. Then there was maintenance for 13 weeks. Since this was double blind, half approximately of the individuals had ganaxolone and half approximately of the individuals had placebo. After the conclusion of the double blind phase, there was a titration phase and individuals were invited to participate in the open label phase where everybody gets the medication. So we're going to talk in a couple slides about the different time points of the study. First, we'll look at the double blind measurements, which are probably the most important in terms of what the true difference is when nobody knows who's on what treatment. And then there's a slide that relates to the open label phase. So I'll do my best to kind of separate which is which, but this diagram is what we'll want to have in mind when we go over those. So this is that first part. This is the results of the double blind primary endpoint, which is seizure reduction and the reduction in seizure frequency. And you can see that in individuals that were treated with ganaxolone, they had a 30.7% reduction in median seizure frequency for the major motor seizures that were the primary endpoint. And you can see that that compares to a 6.9% reduction for patients treated with placebo. And we depend on rigorous mathematical measurements to determine whether this could possibly be due to chance. And there's a definitive answer in terms of the p-value. With the p-value of 0.0036, that's a very, very strong statistical conclusion that these are not the same and that ganaxolone is effective for this primary endpoint. So this, to me, is the most important and exciting thing about answering the question, can ganaxolone help an individual with CDKL5 deficiency epilepsy? There were other ways that we tried to measure the severity of epilepsy. I think if we're honest with ourselves, we all kind of understand that the things aside from the seizures are a profound burden on individuals that have this form of epilepsy, developmental delay, cognitive impairment, things of that nature. So in order to try to measure those things also, which are far more difficult to measure than simply when and how many seizures happen, we looked at the CGI-CSID, and that is the Caregiver Global Impression of Change in Seizure Intensity and Duration. And the goal here is simply having the family members rank whether the individual participating in the study is improved or worse, and for each direction, whether it's minimal, much, or very much improved, or similarly worse. And so the way that we use this information to draw conclusions and to try to get a sense of how helpful this medication is by looking at the individuals who are in the blinded ganaxolone group, which is shown in teal, versus the blinded placebo group, which is shown in gray. And the more effective the treatment is, the more the treatment bars will show up on the left side, and the versus the placebo group, because the placebo group will have an expectation for some improvement because of the placebo effect. And you can see here on this diagram that there is a difference in the histogram or in the breakdown or in the profile of how many individuals were improved on ganaxolone versus placebo in the judgment of their caregivers. We also can look at subgroups within the double-blind outcomes. And this isn't super important, so we're not going to spend a lot of time on it, but we're able to say whether or not there were any differences regionally. We wouldn't expect there to be, and the data certainly shows that different regions responded similarly. We can answer the question of whether or not there's a big difference between males and females who participate in the study, and the answer is no, there doesn't seem to be a big difference. And then we can look at whether or not there is a difference in terms of how many seizures the study participant came into the seizure with versus how effective it was. And we can see that it can be helpful whether you are just over the threshold of how many seizures you required per month to participate, or if you had a lot more than that. So the baseline seizure burden did not seem to be a major factor in determining who would respond and who would not. So now I'm going to shift our attention from the double-blind period, which I pointed out earlier, to the open label extension. And the important thing to recognize at this point is that once you go into the open label, everybody is on medication, and the line between those two groups is right here. It's relatively faint and kind of hard to see, but this is the primary endpoint, which is double blind. And you can see the same percentages we looked at earlier between the treatment and the placebo group. And you can see that after everybody is on ganaxolone, this is what happens over the following 12 months. This last data point here is 12 months following open label extension. So the important thing that we got out of this data set, because it's not double blind, it's much harder to draw conclusions about cause and effect, but we are able to continue to monitor safety, and we are able to confirm that there were no new safety findings that emerged during the open label extension to date. So speaking of safety, let's talk about it in a little bit more detail. We are all familiar with seizure medications and how important it is not only to look at their effectiveness, but also at their side effects, because that is as important of a factor in the decision-making process as you decide what kind of treatments make sense for your child with the help of your doctor. So with ganaxolone treatment, we have two categories shown on the slide. The first is treatment emergent adverse effects, or TEAEs. So treatment emergent adverse effects that happened are shown in that chart on the left-hand side. And the common ones were somnolence, pyrexia, which means fever, upper respiratory tract infection, constipation, salivary hypersecretion or salivation, and sedation. And you can see how it compares in the placebo group and the ganaxolone group. And so I'll just let you have a couple seconds to kind of review those numbers. And it's important to compare both because obviously you can have things like upper respiratory tract infection or fever in any child who's participating in a clinical trial, and whether or not it seems like it's a side effect of the medicine really is a little bit of a judgment call, and depends on how often you see them in the two groups. The other thing, besides common treatment emergent adverse effects, of course, are serious treatment emergent adverse effects. And these are the ones that could be conceivably dangerous or threatening to the health of the individual. Thankfully, these numbers that we're seeing are very low, with any serious adverse event being seen in only 9.8% of placebo individuals and 12% of ganaxolone individuals. So 5 and 6 patients respectively out of, remember, 101 total participants. And again, you can review those numbers yourself. The process of doing a clinical trial is very, very burdensome and challenging for the people that are participating, the study subjects, as well as the investigators who are helping us. But as a result of all that heavy lifting, we get out very, very granular data and have a very solid understanding of what is actually seen in the individuals who take these medications. So we're now shifting gears to the third and last section of our presentation, which relates to the expanded access program, compassionate use. Expanded access with ganaxolone in children and young adults with CDKL5 deficiency is, an answer to the question of, okay, how does the Marigold study help my child, or what does this mean for my family and the young person with epilepsy that we're trying to find better treatments for. So what is an EAP? An EAP is sometimes called compassionate use. It stands for Expanded Access Program. And it's a possible pathway for a patient with an immediately life-threatening condition, in which, in this case, we're talking about CDKL5, of course, to gain access to an investigational medical product, meaning a product that hasn't been approved by the FDA. And it's treatment outside a clinical trial when no comparable or satisfactory alternative exists, except that therapy. So the Expanded Access Program involves the same treatment of CDD with ganaxolone as the Marigold clinical trial, but it's made available to other individuals who are not study participants. Marinus compassionate use recognizes the importance of randomized controlled clinical trials, but also that not all qualified patients have an opportunity to participate in the randomized clinical trials, of course, because the randomized clinical trial in question is completed. So in these circumstances, Marinus will consider providing a physician with pre-approval access to a Marinus investigational drug for the treatment of an individual patient outside of a clinical trial under certain conditions. So in terms of eligibility and enrollment, patients must be at least 2 years of age. They must be diagnosed by their physician with CDKL5 Deficiency Disorder, and they have to be determined by a healthcare provider to be a candidate to receive ganaxolone for CDD. And patients can only be enrolled in the EAP by a licensed physician that is, implicitly implies that they have to be in the United States in order to have that occur. This is a program regulatorily that's underneath the FDA, which is a United States organization. So one important question in terms of whether or not you discuss the EAP with your physician is to know and understand what's involved in participating. In addition to the standard of care, the child plus the parent and caregiver plus the physician have to follow compassionate use procedures, which means that when you visit your doctor, you'll be provided with ganaxolone and instructions on how to administer the ganaxolone to your child. It's a liquid and it's administered 3 times daily. Ganaxolone will be provided to you at no cost. Your physician will need to monitor and record any adverse events that occur, because exposure allows us to continue to learn more and more about the safety profile of any treatment. And your physician will record any changes in the severity of your child's illness. So if you're interested in participating in the Expanded Access Program, Marinus wants to make the process as easy to understand and follow as possible. I think the most important thing is to make an appointment with your doctor to discuss the EAP specifically. And let me pause here, because I think this is a critical point in the constant struggle to stay on top of what's happening with your child. We all have experience with how challenging it is to cover everything in your doctor's visit. If you make an appointment with your doctor just to have a follow-up appointment, you'll discuss everything you normally discuss, and you might run out of time to discuss the EAP specifically. If you make the appointment to discuss the EAP and nothing else, it kind of solves the problem of, I don't have enough time to talk about this, or my doctor doesn't have enough time to think about it. It's a relatively uncommon experience for physicians, and so they need the time to process what's required and whether or not it's practical. So that's the most important point, and it's point number 1. The second and third bullets, though, tell you exactly what to cover and how to how to discuss it with them, you want to visit the EAP portal on the Marinus website to learn more and answer questions that you might have. And the URL is listed there. You can write that down or take a screenshot with your print screen button or with your phone. You can also contact Marinus if you or your doctor has further questions. We'd be delighted to answer questions from any source. Romy is the doctor who introduced me earlier. Her email is there. And Juby Phillip is one of our clinical operations team members who can also help answer any questions that come up. And obviously we can answer them today as well if you already have them on the top of your mind. So if I could summarize briefly before we take questions, ganaxolone is an investigational drug in development for treatment of CDKL5 deficiency disorder and other rare seizure disorders. In the randomized, double-blind clinical trial of CDKL5 deficiency, patients taking ganaxolone had significantly fewer major motor seizures than patients taking placebo. Ganaxolone was generally well tolerated, with the ganaxolone group experiencing less than a 5% discontinuation rate, with the most common adverse effect being somnolence. Over a 12-month open label extension to date, no new safety signals have emerged. And Marinus is sponsoring an expanded access program for eligible patients with CDD to receive treatment with ganaxolone. Marinus remains on track to submit an FDA application, NDA, mid-year, and EMA pre-marketing authorization, called an MAA, in late third quarter of 2021 for use of ganaxolone in CDKL5 deficiency. So with that, I would be delighted to take any questions.
Well, thank you so much, Dr. Miller, for that. As Dr. Miller said, we are open to questions. Is there anything that we can address right now? Somebody in the waiting room here. Okay. Okay, not today. So if there are no further questions, I would like to just again thank the IFCR for giving us this opportunity to present today. And actually, I would like to turn it over to our IFCR colleagues to maybe give a little bit of information on how the recorded presentation will be accessed and where and how to do that.
Yeah, there you go. We'll have it available on our IFCR YouTube channel, and I imagine Amanda just shared it in the chat, and Marinus has access to that as well, so they're welcome to share that on their social media channels, however they like. And we'll be fielding questions as well. So we really do encourage people to ask questions. This is the time you have the experts in front of you. Any caregivers that are here, please take this opportunity to ask them if you have some questions about ganaxolone or that EAP program. It's important to understand it because it really is an opportunity. But they're wonderful. They're a wonderful team, and they'll be available afterwards as well.
And please note, I did put some email addresses into the chat, and feel free to use those to ask any questions about the compassionate use program or anything else that we might be able to provide for you. And please do visit the Marinus website if you're interested in looking at the progression of our clinical trials and our pipeline information. And there's also the portal there for the expanded access compassionate use program that you can go in and explore a little bit more. Okay.
There's a question in the chat.
The question is, any update as to when the medication will be submitted to the FDA? If we go back to the slide that addresses that, I think that's in the very last slide, that we are on track. We are preparing a new drug application, and hopefully we'll be able to get that submitted, and looking to late 2021 for the MAA, and hopefully perhaps in 2022 at some point, ganaxolone, if approved, might be available. I'm going to turn it over to my colleague Sasha. Sasha, would you expand on that anymore?
Yep. So hi, everybody. Sasha Damuni here, head up corporate affairs. Yes, we are on track, as Romy mentioned, to submit our filing mid-year this year. So I know we are in mid-year, so stay tuned. And as Romy said, we expect an approval next year. So very excited about that.
Okay, excellent. Thank you, Sasha. Okay, doesn't look like we have any further questions at this point, but again, we welcome questions at a later date. So again, I'd really like to thank the IFCR for giving us this opportunity, and I hope that this was interesting and educational for all of the participants.
Many thanks to Marinus for taking the time to do this. And just a reminder for all of those who may be watching this later, don't think just because you're watching it later, you can't submit a question. Please feel free to do that. The emails will be where you can see them. And if for some reason you can't find them, you can always reach out to IFCR and we will connect you appropriately. Thank you everyone for your time today and for joining us.
Have a wonderful weekend, everybody. Thank you.
Thank you.
Bye-bye.
Thanks.